All right, so let's get started. So as you can see from the picture, ulcers can develop either in the stomach or they can develop in the duodenum. Essentially, it's possible that they can develop in any area that's exposed to acid and pepsin, and we'll talk more about those compounds in a few minutes. The ulcer forms in the mucosal layer, but it can reach down to the submucosal layer as well. So this diagram is from your textbook. There's a nice discussion associated with it. Feel free to read that discussion to learn more about the aggressive versus the defensive factors and kind of how they interplay to cause ulcers. I'm going to provide a brief review. So peptic ulcers develop when there's an imbalance between the mucosal defensive factors, you can see them on the right of the screen, versus the aggressive factors. So the defensive factors, let's start with those. These are factors that provide protection to the stomach and the duodenum from self-digestion. When intact, ulcers are unlikely. However, when physiologic conditions exist that cause the defensive factors to be weakened, the balance can tip over to the left towards the aggressive factors, and that will lead to ulceration. So let's go through these defensive factors. Mucus is the first one. This is secreted continuously by the cells of the GI mucosa, and essentially it forms a barrier to protect the stomach cells from attack by acid and pepsin. Acid and pepsin are chemicals that are breaking down food molecules. Those molecules are very strong, or those chemicals are very strong, and they can cause destruction of the GI mucosa. So mucus helps to protect the GI mucosa. Bicarb is secreted by the epithelial cells of the stomach and the duodenum also. It remains trapped in the mucosal layer. Remember, the mucus layer of the GI tract has lots of folds, and so bicarb gets trapped in between those folds, and it neutralizes hydrogen ions that penetrate the mucus, and so that helps to protect the GI cells. Blood flow. So blood flow is essential for maintaining mucosal integrity. When blood flow is reduced, that can lead to ischemia and cell injury. It increases vulnerability to damage of those cells. So adequate blood flow is important. Prostaglandins. So these are endogenous chemicals that are very important for maintaining the defense of the GI tract. Basically, these prostaglandins will stimulate secretion of mucus and bicarb. So those first two factors, prostaglandins enhance the volume of those first two factors. They also promote vasodilation to maintain blood flow. So prostaglandins are really important. Ultimately, they also can suppress secretion of gastric acid. So those four factors are very important for those to be intact, and anything that can disrupt those factors can potentially be a problem. Now, on the other side of the equation, we have the aggressive factors. Helicobacter pylori. Does anyone know what this is? So think for a moment. Before I tell you, think back. Where have you heard that term before? What is Helicobacter pylori? So if you said that it is a bacterium, you are correct. It's actually a gram-negative bacillus or rod. This bacteria colonizes the stomach and the duodenum. It lives between the epithelial cells and the mucus barrier, and it can live in the GI tract for decades. It's thought that more than half of the population is colonized with Helicobacter pylori or infected with Helicobacter pylori. Even, some estimates say even as high as 90% of the population. But the thing of it is, only a small number of the people who have Helicobacter pylori in their gut actually become symptomatic. That number is around 10%. Let me show you guys a diagram so we can take a look at the Helicobacter pylori. So here you can see the Helicobacter pylori. Like I said, it's a gram-negative bacteria, and it lives kind of in between those folds, essentially infecting the GI tract. Normally the GI tract is sterile because of the low pH, but this is one bacteria that can live in the GI tract, and not only live in the GI tract, but it's thought that it is the causative organism, the kind of underlying causative organism for peptic ulcers. So the eradication of this bacteria promotes healing and minimizes the risk for recurrence. So patients who are treated with antibiotics to rid the GI tract of H. pylori, their recurrence rate of an ulcer is 10% versus 80% of patients who are just treated with other symptomatic medications but don't actually treat the underlying cause. All right, so let's talk about some other aggressive factors. NSAIDs, this is another very important problem and medication-related problem, of course. So NSAIDs, now we haven't learned about those drugs in this class yet, but we will talk about them towards the end when we talk about pain management. NSAIDs are non-steroidal anti-inflammatory drugs. The ones that you probably have heard of, ibuprofen. You may also have heard of celecoxib. These are examples of first and second generation NSAIDs. These are the underlying cause of many ulcers. How, you might ask? And basically, NSAIDs impact or actually inhibit the biosynthesis of prostaglandins. So remember when we talked about those defensive factors, prostaglandins are very important because they influence mucus and bicarb production, and they also influence blood flow to the GI mucosal. All three of those things are very important defensive factors. So NSAIDs inhibit the synthesis of prostaglandins, and then you can imagine what happens. We have decrease in submucosal blood flow, suppression of secretion of mucus and bicarb. And then in addition to those factors, the NSAIDs, the drug itself, the chemical itself, they're also direct irritants to the GI mucosal. So kind of all of those factors combined, these are a very important aggressive factor. NSAID-induced ulcers are more common when patients are on high-dose NSAID therapy for a long, extended period of time. Some of the other factors, acid. So this is an absolute requirement for ulcer development. So it's really the acid that is impacting the development of the ulcer. But remember, it's the those other factors deteriorating and conditions being pro-acid development. So the acid itself directly injures the cells of the GI tract, indirectly causes activation of pepsin. So pepsin's also going to be a factor in degradation of the GI tract. So acid's important. Acid has to be present for ulcers to occur. Pepsin is a proteolytic enzyme. It's present in gastric acid juice, and it is also responsible for causing direct injury to GI tract cells. And then finally, smoking. So smoking delays ulcer healing and increases the risk of recurrence. And essentially, this is because smoking can decrease the effectiveness of drugs, so it actually can influence and interact with how well the drugs can work that we use to treat ulcers. Additionally, smoking can cause accelerated gastric emptying, and that can result in acid being deposited into the duodenum, which can cause duodenal ulcers, which is one of the biggest issues with smoking. So kind of looking at this, just having an understanding of the defensive factors and the aggressive factors, it really informs how we would potentially approach treating ulcers. Before I talk about the drug treatment, though, I do want to just briefly talk about GERD. GERD is gastroesophageal reflux disease. This is a pretty common disease. It's characterized by heartburn and regurgitation of the GI contents into the esophagus. So with GERD, you may or may not have ulceration. So unlike peptic ulcer disease where you always have an ulcer, GERD, you may or may not have an ulcer. It's pretty common in both adults and children, and it's due to inappropriate relaxation of the LES, which is the lower esophageal sphincter. So that reduced tone of that sphincter allows the GI contents to reflux into the esophagus. And this could be transient relaxation that's occurring, or it could be sustained relaxation. But essentially, it could be secondary to other underlying causes like a hernia, hiatal hernia, or obesity or delayed gastric emptying, causing pressure. Could actually be related to drug therapy as well, which we'll talk about in a few minutes. Some of the common symptoms that patients describe are heartburn, regurgitation, dysphagia. So in this picture, you can see, you don't actually see an ulcer in the GI tract like you do for peptic ulcer disease. But basically what you see is your acid kind of coming back up into the esophagus. And you can see kind of at the junction of the stomach and the esophagus, there's that area where you've got your lower esophageal sphincter, and that's inappropriately relaxing, allowing those contents to come back up. And so this can be a very serious disease. It can cause ulceration in the esophagus, and it can actually lead to serious diseases, even cancer of the esophagus as a result of this underlying problem. So GERD can be treated with drugs or surgery. It really depends on the severity. Some patients have, like I mentioned, erosive esophagitis, where they've got actual ulceration. This is pretty serious, probably going to be treated with surgery or even a combination of maybe drugs and surgery. But other things that can be helpful are lifestyle changes. So when you have patients that experience GERD and they're on drug therapy, it's wise to inform them of some of the lifestyle changes that can help reduce their symptoms. So you can see there's a pretty exhaustive list here, like stop smoking, lose weight, avoid alcohol, late night meals, sleeping with your head of bed elevated, and other things that are listed here. Going down to the bottom of the list, avoiding peppermint, garlic, onions, and chocolate. So these are foods that can aggravate symptoms because they actually decrease the lower esophageal tone, and then that sphincter is relaxing and allowing for regurgitation.